Good afternoon. At the outset, let me thank Dr. Manavi to have me here. Yeah. What is happening? Thank you. So it's a very short time to cover both IOL and nucleus drops. So we'll try to directly jump. I'm not going to just talk about theory. So the drop nucleus, you can have either it can be entire lens with the capsule, or have nucleus or part of it, as you see here, or cortex and part of it, or fragments of both nucleus and the cortex. So what should the cataract surgeon may do is to see here, it's like a started your phaco and it just sinks. So, and thus it's gone. So if you try to make too much of attempt here, you will end up in a problem. So most important thing here is stop the surgery, do thorough assessment of your damage, and when you are thinking about you are getting over this mishap, what happened, meanwhile you request them to get vitrectomy setting ready if you have your VR surgeon with you, or yourself a VR surgeon, and vitrectomy setting is there, get the things ready. So the various scenarios we discussed before, and what I'm going to concentrate is last one. You have a mid or posterior vitreous cavity, fragments are gone. First four scenarios probably your cataract surgeon can deal well with better than any VR surgeon actually. So when you have a fragments in mid and posterior vitreous cavity, you obviously need sparse plana approach, and it's better to complete the surgery at the same sitting if possible. And if you have a cataract colleague to help you out, please call him and get vitrectomy setting ready. But if it's not possible, it's best to do a thorough anterior vitrectomy, maybe triamcinolone assisted. First presentation has already shown how to do actually the anterior vitrectomy if you have over the lens. Try to remove all the fragments sitting in anterior chamber. Ensure that your cataract wound is watertight, preferably if necessary, use sutures. And if drop nucleus is very, very hard, please avoid IOL at this stage. Now we have a best fragmentum, and you can even grade 4, grade 5 black nucleus, though we can do fragmentation, but preferably avoid now if possible, because we do not know how the situation will be, scenario will be at a later stage. And obviously treat the patient with topical steroids, cycloplegic antibiotics, monitor intraocular pressure if necessary, start on a medication, and pass on patient to your VR colleague. So as I said, removal ideally should be at the same sitting. A lot of psychological, emotional, financial issues are there. But if not, is preferably should be done within first 2 weeks. But if you have associated posterior segment complication, again, earliest is the best option. So we have a good pre-op dilated fundus examination. If view is not there, do B-scan ultrasonography to assess the posterior segment. Most of the cases we manage under local anesthesia nowadays, but if patient is very, very apprehensive and already gone through the trauma, general anesthesia also can be given. That's not an issue. Examine the cataract wound properly for a leakage or whether there is a vitreous incarceration, because that can create a problem during your vitrectomy. And so if wound is leaking, please reinforce wound before start your sclerotomy, before even making your sclerotomies. So this is typically what happened. So there are two different ways. Obviously, you have to do a good vitrectomy in both the sides before attempting lens removal. Here we are doing a mid vitreous cavity fragmentation. Here I picked up the lens, was very hard, got up in an anterior vitreous cavity, holding on a MVR blade, and subsequently chop up with your fragmentum, both with fragmentation. But what is important is thorough good vitrectomy before attempting this, because if you see this lens falling up and down and your fragmentum goes in and out, particularly if you see here, and if your vitreous is this area, it can drag your vitreous, you can create a dialysis within no time. So ensure you clear the vitreous thoroughly before attempting removal of the or chopping of the nuclear fragments. And this is probably what you see is the end of the surgery here. Before you close this case, again, you ensure, use your indirect ophthalmoscope to thorough peripheral examination that there are no iatrogenic problem. Not only because iatrogenic problem created by VR surgeon during removal, but whether inadvertently something would have happened while trying to retrieve the nucleus by your cataract colleague, that also you need to look at it, because sometimes Unless you remove this, you will not be able to examine the oral area in these eyes. And these are few complications you can see here. I had one case with a giant ear, landed a bit with a bad PVR. We have, while fragmenting nucleus, the nucleus fragments were just thrown up, hitting on the retina, and then this created the retinal hole there as well. And ultrasonography energy, when you use ultrasound energy close to the retina, that itself can be detrimental to the retinal health. And then these are previous literature report, fairly good success rate, 20/40 or better vision, almost up to 80%. As you see here, we have one of our postgraduate did his thesis about 90 cases of drop nucleus, whether our in-house or referred to us for subsequent management. In his series, we could achieve somewhere almost around 60% of patient had a vision better than 20/40 and 85% had better than 6/18 vision. So what are the do's for a cataract surgeon? Stop surgery and do proper assessment. Manual or vitreous delivery if lens pagarates are in a pupillary area. Clear vitreous of the section and antechamber and the closed section tightly with suture and call VR surgeon if possible. Do not attempt to follow or remove fragments sinking in a vitreous cavity. Avoid blind fishing. There is no phaco or suction should be done in a vitreous cavity. We cannot fragment the vitreous. You will just pull vitreous and create a problem there. Avoid excessive handling and damage to cornea and retina. Avoid irrigation of the vitreous cavity to retrieve fragment. Vitreous lavage or levitation doesn't help if you have vitreous gel. Please do not do that. And never use bare cryoprobe within the form vitreous. Again, if you use a cryoprobe, you are freezing the vitreous around it, and then when you remove it, you are pulling the vitreous along with the lens as well. And avoid silicone oil definitely, because it can create a problem for you. What is happening? Again, video is gone. Now basically wanted to show this is what is happened. IOL is there, and behind that what you see is a nucleus is left behind, and this was the retina when we operated, when patients are referred to us. So yes, that is what happened. If you try to fish out what exactly that previous video shows, like please do not push your wire vectis within the vitreous cavity. Entire retina is macerated. There is practically no retina left here. Please avoid these maneuvers. How do you want to explain this to patients? Rather, I would prefer direct approach to inform that an unexpected complication has occurred and it can be corrected without compromising the visual outcome. Basically, that's why it's important if you can take care of this complication during same sitting, that's better. You can tell something was wrong and we have taken care of everything. So it is better, patient accept that is much better way than telling them to go to one of your colleagues. Please do not hide or downplay or try to place the blame somewhere else, because today's scenario, obviously, lot of litigations we are having, I think that can put us in a problem. And the sum up is the avoiding vigorous attempt to retrieve intravitreal fragments and timely referral to the VR surgeon for vitrectomy and complete removal of lens fragments can result in generally a good visual recovery. I think I think drop it because it's no time left. I think so. I'll stop here. So have discussion, anything, we'll continue further.